Okay, anesthesia is serious, and almost everywhere in the world, if you get anesthesia for major abdominal surgery, they give you a gas to breathe as part of the anesthesia. In fact, the very first anesthetic was ether, and that was done back in like 1865 or something like that, before the Civil War, and in Harvard, where they had a dentist give a guy anesthesia, and they took out a tooth or something. Since that time, almost every anesthesia that's done around the world uses this gas type of anesthesia. Now, we don't use ether anymore because it tends to explode. But the gas anesthetics are great because right now they're cheap, they're very effective, but they have two disadvantages. One is very unpleasant and one is dangerous. Almost one person out of every three who has a gas anesthetic will wake up with severe nausea and vomiting. And it's no fun. Tremendously nauseated, retching after surgery, and that's no fun. The other thing about gas anesthetic is they are a chemical which is fat soluble. You know, like when you're making Italian dressing with oil and vinegar, oil and water don't mix. You can see them in the bottle. Well, gas anesthetics are oil-type drugs, that is, they're lipophilic or fat-soluble, and so when you breathe them, some of them dissolve in the fat. So then when you turn off the gas, you wake up very quickly, which is good, but you may have enough fat stored gas so it can creep back into the bloodstream and actually act as a sedative that's unexpected. And then you might be in the recovery room, the gas might come back into your bloodstream enough so that with pain medicine and other things, all of a sudden you stop breathing. And so there's a danger that could be deadly that the gas could unexpectedly come back into your bloodstream. Now that's uncommon, but especially if you're overweight and then you have abdominal surgery and then you need pain medicine, that combination can be a dangerous combination, especially if you come to us already with lung disease like sleep apnea and breathing on a breathing machine. So we don't use gas anesthetics. We use another kind of intravenous anesthesia called TIVA, which is just an abbreviation for totally intravenous drugs. And the intravenous drugs do not cause nausea and are not lipophilic or fat soluble, so the risk of respiratory depression is decreased. Sounds good so far. But now there's another area of research because there's another set of drugs we use for most anesthesia, and that's the pain medicines, you know, like morphine and Demerol and Percocet and other narcotics. And narcotics, like the gas anesthetics, have two side effects. Guess what they are? One, nausea and vomiting. So if you get narcotics, right, you can have nausea and vomiting, which we don't want. But more dangerous is narcotics depress breathing, just like we talked about the potential risk with gas. So we want, for compassionate reasons, to give our patients lots of pain medicine to take away their pain, but we fear the risk that we could stop their breathing. Okay? So there's a whole area of research now called opioid-sparing anesthesia. That means anesthesia which uses less narcotics. So in your anesthesia today, you're still going to have narcotics as a rescue available. What we'd like to do is give you other drugs that decrease your pain, but not call in the rescue team, or at least call it in with less, so that we have less risk of the respiratory depression and the nausea. And the drugs we're going to use are drugs called ketamine, which is an old-timey drug, which has been around for a while. We're going to use it at a low dose, and it stimulates respiration, stimulates blood pressure, doesn't cause nausea, and decreases the need for narcotics. We're going to use a brand new drug you might not have heard of called Precedex or dexmedetomidine, and that is also a drug that stimulates respirations but gives you good sedation. And then we're going to use a drug you've heard of that you can buy in the grocery store that you have gotten last night called melatonin. Now in all these drugs, if you give them to patients pre-op and give the other group, without knowing it, a sugar pill, after surgery they'll have less pain and use less narcotics. So today you're going to get the therapy that we talked about called opioid-sparing anesthesia, and we're going to use ketamine, dexmedetomidine, and melatonin, and a couple of other drugs, all designed to decrease your pain without decreasing your breathing and without causing nausea. And that's why I think you saw yesterday all those patients who had surgery, not one of them said they had any problem with anesthesia.
Okay.